Now, one of the big questions in flexor tendon rehabilitation is, what is early motion and when can we start early motion? Let's review. For this part of the discussion, we're going to talk about early mobilization as moving the tendon with any protocol other than immobilization. We will later discuss in more depth early active motion and when to begin that motion. Early mobilization is better than immobilization. We know this because if you wait too long, there will be significant adhesions of the tendon to the surrounding bed, and there will be very limited glide possible, in addition to which there are secondary stiffness in the joints and other adherence of soft tissue that has not been moved. But the balance of that is, if you take any newly repaired tendon, you move it too much, too soon, or with too much load, you have a very high risk of rupturing the repair site. Historically, flexor tendons were immobilized, and over time, since early mobilization began to be used, the extent of motion allowed has become greater and greater. That is not only because we know more about flexor tendon healing, but it's also a change in type of suture and the suture material and many other variables. This graph helps us understand why so many are strong advocates of early motion. If we look at the bottom three lines of this graph, these three lines are representing three different suture sizes of tendons that have been immobilized. The normal healing actually causes the tendon ends to soften and degrade in the process of replacing them with new healing tendon. So these tendons become weaker and weaker until at about 3 weeks they begin to increase in their strength to resist rupture. But if we look carefully, we see that none of the three reach the same strength they were on the day that the suture was placed in the tendon. And that's because the quality of the tendon has changed and the suture cannot hold firmly onto a really soft tendon end. We then take these other three lines, which represent tendons that have been constrained, meaning they've moved only a small amount and they have the same suture sizes in them. But here we see, by moving them very early, that there is a dramatic and progressive increase in strength. And at the same 21 days, they far exceed this tendon at its lowest, and they all begin a steep upward climb to be significantly stronger and resistive to rupture than at 40 days. So immobilized tendons are weakest at 3 weeks. For that reason, many would say that you should not begin active motion at 3 weeks. You should begin it either earlier to increase this graph or after the 3 weeks as the healing is starting to become stronger. However, what we do not know is whether or not we could do some type of movement at the 21 days safely and could alter this graph dramatically so that it too begins a greater and steeper upward climb. What we do know, however, is that early motion, any protocol that moves the tendon, does increase the strength of that tendon repair and allow loading earlier. I'm sure one important question you would like a better answer to is, when should I start moving a flexor tendon repair? Well, that's really very difficult to answer precisely because there is conflicting literature about the ideal time, and the healing variables, one patient to the next, highly different. Therefore, you have to consider a number of variables to make sure that you're safe. When is it safe to start mobilization of a repaired flexor tendon? There is no one absolute answer. There are so many variables related to the healing and the wound, the individual, the surgery that was done. In addition to that, the literature provides conflicting suggestions as to when the ideal time may be. But we do know generally that during the first postoperative week, it is a safe time to start the appropriate mobilization protocol. Hopefully, as we go through this presentation, it will be clear that not all protocols are appropriate for all patients, regardless of the time that they are started. I prefer to start flexor tendons moving no earlier than 3 to 5 days post-surgery, because the wound created by the surgery enjoys the brief period of immobilization and compression to minimize both the edema and the reactive inflammatory response, which is a normal postoperative response. In the chicken model, resistance to motion was measured from 0 to 4 days, from 4 to 7 days, and beyond 7 days. Now, in 0 to 4 days, there are no adhesions, but there is this postoperative inflammatory response, and that alone, I believe, increases resistance to the movement of the tendon. Between days 4 and 7, that level of resistance remained consistent. But beyond 7 days, without movement, adhesions were beginning to form, and that, of course, greatly increased the resistance. So from this work and others, it appears to me that that ideal is between 3, 5, 4, 6, 7 days to begin any kind of early motion protocol. So my conclusions would be that early mobilization is more desirable than immobilization. That is because the repair will be stronger as compared to immobilized tendons, and it appears that the first 4 to 7 days is the best period of time to begin any early mobilization protocol. Remember, early mobilization does not mean active mobilization. It means that you simply are not immobilizing the tendon.